तिला वाटलं तर लिवायचं नाही का नाही. असं आपलं काम आहे, कशावर अडून ठेवायचं नाही आयुष्यात अडून.
Hello everyone. Rajesh sir, should we start? Okay, I think there might be some network issue on his side, I guess. So I would request all of you to just mute yourself during the session, please. I think we should start our session on CBT for bipolar. I'll quickly introduce myself. I think Rajesh sir has joined now. Sir, are you able to hear us?
Hello, Asira.
Yes, sir.
Yeah, you can continue the session.
Okay, fine. So, I will quickly introduce myself. I'm Asira. I've done my master's in clinical psychology and later I've done my specialization in CBT and REBT therapies. I have my own center, Athar Center for Psychotherapy and Training, which is in Thane, and I've been practicing for more than 5.5 years now. Our session is going to focus on CBT for bipolar. We have this session for some like till 8 p.m. and then tomorrow again 6 to 8. So we will quickly try to understand in our session what is CBT's understanding when it comes to managing bipolar disorder. I would really appreciate if most of you can be on your videos because that would be more interactive. And as a facilitator, I like to see my audience rather than just me talking to my own self. I would prefer that. Yes, good evening, everyone. During the course of the session, I would really also like if you can post your comments in the chat box because we have limited time, right? So, then I can take your questions as I'm going ahead. And again, muting yourself and unmuting yourself, that takes too much of time. So I would really like to use these 4 hours as efficiently as possible to help you understand my little knowledge about bipolar. I'm saying little because CBT for bipolar is still growing. There's so much research that's coming up and understanding of bipolar, understanding of the symptoms, and most specifically the psychotherapeutic models for bipolar. It's very, very extensive, right? So I'm going to really give you a capsule knowledge of bipolar disorder with CBT in these 4 hours. Beginning with, definitely I'm going to look at some very specific to the point features of bipolar 1 and bipolar 2. Remember, our workshop talks about CBT for overall bipolar. So I have not differentiated bipolar 1 treatment and bipolar 2 treatment because that would need, again, more extensive understanding, more time also. I'm going to look at overview of CBT for bipolar, which includes both 1 and 2. But to be honest, CBT has got its own bipolar 1, bipolar 2 also. It's very, very intense. Now, bipolar 1 disorder, in terms of specific features, we have to understand that in bipolar 1, it is necessary to meet the criteria for a manic episode. This is very, very important. Meeting the criteria for manic episode. Now, DSM-5 is something that we should follow when it comes to understanding of bipolar. So if you go on Google and type DSM-5 criteria for bipolar, you will get a very good PDF where the criteria has been given. So manic episode is a must for bipolar 1, and it can be preceded or followed by either by hypomanic or major depressive episode. But it is not a must for the diagnosis of bipolar 1 to have hypomanic and major depressive episode. Now, when it comes to manic episode, because this is a predominant feature for bipolar 1, manic episode means abnormal heightened mood, very, very elevated mood, irritable mood also, that is seen in our patients. There is increased energy also, increased goal-directed activity. They just want to do so many things. Like with my client, I remember she just wanted to achieve and get onto these tasks, right? Which again may not be. These symptoms last for at least 1 week, and they're present most of the day, nearly every day also. And some, if they're very intense, it might even require hospitalization. Okay, I'm following DSM-5 only in helping you understand this. Remember that manic episode is a must here for bipolar 1. Okay, now during the period of this mood disturbance in manic episode, 3 or more of 7 symptoms must be present. Out of 7 symptoms, 3 or 4 must be present. 3 or more, sorry. So most common symptoms for manic episode are grandiosity, where they feel, that they have inflated self-concept is seen. Then you also see decreased need for sleep. They just don't feel like sleeping. They might even feel rested for even if they are sleeping for 4 hours, they might feel rested. They are more talkative than usual. They want to talk a lot. Lot of flight of ideas, too many ideas going through, thoughts are racing. Distractibility, they are not able to concentrate on tasks. Sometimes, they are trying to concentrate, but they are getting easily, alert by external stimuli. That is also happening. Then increased goal-directed activities, again, one of the major symptoms here. So it could be either sexual interest, sexual activities, work-related activities, performances, in terms of interpersonal activities, that is also seen. And excessive involvement in activities that have a high potential for painful consequences. Means what? Impulsivity is also seen. So let's say they might buy many things. I have seen with some of my patients, they would just get into these shopping sprees, buying sprees. Also sexual activity. Sometimes in terms of investments also. Not thoughtful investments. Very, very high risk investments without thinking. Dr. Pooja also says gambling, very true. So these are some of the symptoms that you see. 3 or more should be present. And remember, they definitely cause significant impairment in their social, occupational functioning. And as I said, sometimes it might also require hospitalization. And in bipolar 1, there can be psychotic features also, like hallucinations and delusions. Grandiosity-based false beliefs. I have some special talents. These kind of delusions are also present. Obviously, again and again, I'm saying bipolar 1, the distinction is manic episode needs to be present. Presence of hypomanic or major depressive episode might be there, but it is not a predominant factor. Now, when it comes to hypomanic episode, what are the features? Quickly, I'm going to tell you. Here, these symptoms must be present for at least 4 consecutive days, okay? 4 consecutive days. They should be present most of the day or nearly every day. Now, which are these symptoms? Again, 3 or more of the following 7 symptoms, which we even saw in manic episode. The same symptoms apply even for hypomanic. But what is the difference in hypomanic is, they may not cause severe impairment in social or occupational functioning. And it may not even need hospitalization. And there are no psychotic features in hypomanic episode. But you will see others will observe, like some caregivers, they observe these kind of changes and they are these changes in their mood are seen by caregivers in hypomanic episode. Okay, so this also might be present, hypomanic episode, or there is major depressive episode. Now in major depressive disorder also, major depressive episode also, what we have to see is the presence of symptoms, 5 or more, for 2 weeks, the same 2-week period, okay? For 2 weeks, these need to be present. 5 or more symptoms from the list that DSM-5 has given. 9 symptoms DSM-5 they have charted out, 5 or more should be present. But at least one symptom should be depressed mood. At least one should be what? Depressed mood or loss of interest and pleasure. That is a must. The 9 symptoms which DSM-5 talks about in major depressive episode are depressed mood nearly most of the day, then diminished interest in pleasure, right? Significant weight loss is seen in some patients, or even weight gain. Insomnia or hypersomnia is seen nearly every day, right? Agitation, psychomotor agitation is seen. It is generally observed by others also. There is loss of energy, tiredness. Clients might feel worthless. Very, very guilty also they might feel. Inappropriate guilt, right? Then inability to think clearly, to focus on tasks clearly. A lot of indecisiveness is also seen. And recurrent thoughts of death. But remember, this is not just fear of dying, but a lot of thoughts in terms of suicidal ideation is also seen here. But DSM-5 says there may not be a specific plan for committing, suicide or thinking about suicide also. But suicidal ideation can be present. But remember, there are 9 symptoms. The diagnostic criteria says 5 or more from these 9 symptoms must be present. And there should at least be depressed mood or loss of interest. The symptoms for, when it comes to major depressive episode, they definitely cause clinical distress in the client's social, interpersonal, occupational life, or other areas of, functioning. So again, a quick recap: in bipolar 1, at least one manic episode must be present. Okay, and there it could be preceded or followed by hypomanic episode or major depressive episode. This needs to be very, very clear. I would definitely suggest all of you working with a psychiatrist is most important here. You have to work in association with a psychiatrist when you are helping clients with bipolar disorder, because sometimes it is so complex that psychiatrist expertise and knowledge is needed, and collaboration with them will help you also to design your treatment plan accordingly. Now, when it comes to bipolar 1, I have seen some very important features in my clients. They're excessively cheerful at times. So they feel as if they're on the top of the world. This is also one of the problems I've seen, because such clients think that they need no treatment. They are in denial. So I have seen bipolar 1 is really difficult to engage in therapy or even in treatment adherence. I'm going to talk about CBT model there, but highly cheerful. And the mood is very excessive. So it can have, it can even impact their interpersonal relationships. It's not a very functional enthusiasm. That's why I've seen some, like my own client, she used to take up so many projects which were not even possible for us to imagine, like one after the other, multiple overlapping projects. And the client didn't have sufficient knowledge also about certain projects. That I remember she wanted to do ecotourism and enroll for a course and everything without understanding the scope of it, whether she has the aptitude for it, nothing. Invested money also in that course. So this is what, they may not have knowledge of the topic. They might just get into enrollment due to that over enthusiasm. And I've also seen the self-confidence also becomes very unrealistic. It is not appropriate to what it was before the episode. Kind of seems delusional. at times. So they may not have particular expertise or talent, but they might take up such kind of tasks. Another thing with my client, I have observed that decreased need for sleep. And let me tell you, this decreased need for sleep is also one of the, what you say, onset, a sign, an early sign of bipolar 1 many a times. Then speech becomes very rapid, very loud, very pressured, you know. This is also an important sign that you see. Then sometimes it is also very intrusive. Their communication is very intrusive. They may not wait for the other person to discuss or to say their point. Sometimes a lot of jokes, critical jokes, they crack. They are very loud, forceful in their speech, and hostile comments are also very common in some clients. Obviously, I'm just giving you a brief idea. Each client will have her or his own presentation. With my client, I also saw a lot of flight of ideas from one goal to another, just wanting to do a lot of things. And in, you know, a lot of restlessness, which I already covered, distractibility. So there is restlessness also. And excessive planning. So I remember she used to sit with these elaborate planners where there is no action plan, but continuous planning of her days. And the plan also, you know, if you look at her schedule, no time for break, one after the other tasks. Her relationships also changed. She became more hostile in her relationships. I remember during her episodes, she also got into a breakup. Again, very, very, what you say, because of indecisiveness, they're not able to really think of the consequences that clearly. So interpersonal hazards are also very common, unfortunately, with them. And increased sexual drive is seen, fantasies are seen. So many a time shifting from one partner to another is also very common. Right? So we just have to be alert to these very, very important symptoms. And Dr. Pooja already covered that, but antisocial behavior and gambling also is seen in some manic episodes. Right? Sometimes they might get physically threatening, you know, they might threaten physically also. That's where you have to look at hospitalization. And that's where I said this therapist also needs to be in touch with the psychiatrist. That's most important here. Because sometimes there could be catastrophic consequences of a manic episode also. Difficulties with law-related issues can also come up. Serious financial difficulties can also come up because of poor judgment, insight, and awareness. Okay. You see bipolar 1, 18 years or up, generally, that kind of an onset. And I would say that family history, obviously, when it comes to the risk factors, family history is very important. There are genetic factors here. Then you also look at their environment, what kind of environment they have been in. That also promotes, or you could say contributes. In females, you see more, you know, comorbidity with eating disorders, right? Probably you would see more major depressive episodes than males. This is also something which is important. So this is about bipolar 1. Now, in terms of comorbidity, unfortunately, there is comorbidity here with anxiety disorders, especially with my client, I had seen social anxiety. So comorbidities with anxiety disorders, it could be also with conduct disorder, right? And substance use disorder as well. So these three we have to look for. Obviously, because of comorbidity, then the entire understanding, case conceptualization, management of the symptoms will change. Now coming to bipolar 2. In bipolar 2, what you have to understand is meeting the criteria for current or past hypomanic episode. No manic episode, hypomanic episode. And current or past criteria for major depressive episode. So there is no manic episode in bipolar 2. There is, you have to meet, the client has to meet the criteria for a current or past hypomanic episode, and current or past major depressive episode. Hypomanic is again abnormal elevation in the mood. It is very expansive, irritable mood, increased activity or energy, but this lasts for 4 consecutive days. Present mostly, nearly every day and most of the day. Again, 3 or more symptoms they have to meet from a list of 7 symptoms, which we already saw in bipolar 1 also. So quickly going through these 7 symptoms, again, first is inflated self-esteem, then decreased need for sleep. They are very talkative than usual, lot of ideas, flight, racing thoughts, distractibility, increase in goal-directed activity, and excessive involvement in activities that will have painful consequences. As I said, sexual relationships and buying, excessive shopping. Now, again, for hypomanic episode, these mood changes are observable by others. But remember, hypomanic episode is not severe enough to cause significant impairment in their daily functioning, or to hospitalize them. There are no psychotic features in bipolar 2 for this hypomanic episode. They say that if there are psychotic features, then it is manic episode only. So at least 1 episode of hypomanic episode and major depressive episode. Now, major depressive episode also, we covered the same points. So again, 5 or more from 9 points, from 9 symptoms that DSM-5 they have listed. Again, the time period is during the same 2-week period. And there is a observable change from previous functioning. Definitely for major depressive episode, the symptoms do have they do cause significant distress or impairment. So at least 1 hypomanic episode and at least 1 major depressive episode for the diagnosis of bipolar 2. There has never been a manic episode. This needs to be very, very clear. Now, in terms of bipolar 2, what I have seen is obviously noticeable change here also. You see a lot of fluctuations between depressive episodes and hypomanic episodes. But what they say currently is, when it comes to bipolar 2, the depressive episodes are very intense. They're quite chronic. Right? Their depressive episodes are more frequent also. They are more lengthier than bipolar 1. And generally they come to therapy, or let's say not even therapy, they will meet a doctor for their major depressive episode. They will go to a psychiatrist with complaints of major depressive episode. They will not complain for any, hypomania episode. And the impairment also that you see in bipolar 2 comes largely from major depressive episode. Are you understanding this? And for both bipolar 1 and bipolar 2, you need to speak with caregivers. You need to take their feedback and their observations also. So comparing it with bipolar 1, bipolar 2 will have greater chronicity of illness, more time they will spend in the depressive phase of their illness, and it is more disabling, the depressive phase, than the bipolar 1. And again, you see impulsivity here. That's why suicidal attempts and comorbidity with substance use disorder in bipolar 2 is very common. Again, here you see comorbidity with anxiety disorders also. And in bipolar 2, what is observed, there is heightened creativity. Heightened creativity is there. So you just have to be a bit vigilant about what they are doing with that heightened creativity. Again, here the onset starts in bipolar 1, we saw 18. Here it is mid-20s. That is another difference. For bipolar 2, the onset is mid-20s. It is later than what we saw for bipolar 1. The phase of bipolar 2 generally again begins with major depressive episode. And it is not recognized as bipolar 2 until there is a hypomanic episode, because unless and until there is hypomanic episode, you cannot recognize bipolar 2. It's a bit difficult here. Right? So we need to remember this. Now, when it comes to risk factor, again, for bipolar 2, also genetic predisposition, genetic and physiological risk factors are there. So we need to, like when we are psychoeducating family members, we need to really highlight these contributory factors also. Suicide risk is higher in bipolar 2 disorder than bipolar 1. So that's why, again, following up with psychiatrists, taking continuous inputs from them, sharing your therapy notes with them is going to be very, very important. And because of this major depressive episode, you see that there is prolonged unemployment for bipolar 2, for patients who are suffering from bipolar 2 than bipolar 1 again. Okay. And they say 70% of patients who have bipolar 2, they will have some or the other anxiety disorder. So comorbidity again is very high in both. And that's where I have found it's very tricky for the management. I think for me, I have come across the trickiest disorder of all is bipolar disorder in whatever practice that I have till now. Because once the comorbidity also sets in, and if that is present, it just becomes very, very difficult. Right? So these are some very important pointers when it comes to specific features. You need to go through DSM-5 properly. And I would say always keep the DSM-5 with you in terms of bipolar 1 and bipolar 2 signs and symptoms, because then you also have to educate these signs and symptoms to the parents and the family members, other family members. Is there OCD, as in you're talking from the comorbidity point of view? Yes, there could be. That is also seen prevalence. Now, coming to, because you asked me this, I would say most common is substance use as in terms of comorbidity, okay? Now, when it comes to specific features, these are some of the features that we have to remember, okay? Now, I have been asked many a times by my patients only that why did I get diagnosed with this? So, contributing factors, environmental are also there. Okay, I shared with you genetic factors, and there are sometimes gender related implications also, but environmental factors are also there. Like I have seen divorced, separated or widowed individuals, there's high prevalence. Then exposure to traumatic events, that is also very, very important. Then stressful life events like job-related issues, financial issues, interpersonal trauma, interpersonal relationship-based trauma, childhood trauma, especially bullying, very negative, punitive parenting styles. So there are also environmental factors that are seen. Okay. So share the DSM-5 criteria on group. I'll tell you, I did not find an easy PDF for DSM-5, and there is one available on Google, but I don't want to share that because it is not ethically right for me to share it. So what I would do is I will share one PDF that I have from another institute, which is available for free, and there is no ethical concern. That I will share. But DSM-5, please invest in the book, I would say. Buy that DSM-5 book because it's going to be very helpful. Or on Google, you will find PDFs, but I'm not going to take the responsibility for sharing that from ethical point of view, okay? Now, Indian statistics for bipolar, I'm going to also talk about them. When it comes to Indian statistics, we will see what are the major ones. I'm just going to share my slide for that. PPT, yes, definitely you have PPT. So just wait for it. Now, when it comes to Indian statistics, what I have found is 1 in 150 people are diagnosed with bipolar disorder. right? When it comes to generally the age onset between 20 to 30 years, women have more depressive episodes, men have more manic episodes over the course of lifetime. Then the majority of Indian studies, you would see the onset between 25 and 30 years, with only 15% to 20% with an onset less than 18 years. The major difference between Indian and Western studies is in the predominance of mania. Among Indian studies, we have found the first episodes are more frequently manic episodes outnumber depressive episodes during the illness. But remember, this is just a few studies that we are looking at. I definitely would like to include this slide because when it comes to our work with our clients from India, we need to at least know what is happening. What I have decided from the presentation point of view is I'm going to look at CBT model for bipolar. So what we will start with today is basic understanding of what steps we can take from CBT point of view when we are understanding our client and when we are looking at treatment protocols. Okay, so today my major focus will be on engagement with the family. That's first point, what we are going to talk about. Then how CBT can help our patients or our clients. Then starting with understanding bipolar disorder for our patients and for our family members also. What should we cover in intake interview? So let's say as a therapist, if you're interviewing your client with the psychiatrist, then from a therapy point of view, what kind of intake points you would consider? I will look at those also. Then managing non-adherence. Then symptom education is what I will focus on today. And common prodromes. I'm going to tell you what are prodromes, etc. And some early signs, how to detect them and what are some of the coping strategies. So the first focus of CBT model is going to be on helping them understand the disorder. Let me tell you, bipolar disorder, many a times clients themselves have no understanding of the signs and symptoms. And that is the major factor to why they are so much in denial. Okay, so we will go step by step. And I would suggest, again, I'm mentioning this, if you have any questions or insights or your own reflections, let's keep it rolling through the chat. I will make sure that I go through the chat, okay? Now,
मॅम मी बोलले तर चालेल का, कारण मला लिहायला खूप वेळ लागतो.
Manisha ji, I would suggest for this workshop, to probably last 10 minutes I would do a discussion. That would be more helpful, to be honest.
ठीक है ma'am.
Which first model, Parvati? Anyway, I'm going to show you the model so you can just look at the slides.
That you mentioned just now, I just forgot.
It will come on the slide, so that time you can see. If it doesn't come, you can let me know.
Yeah, sure.
Now, CBT model for bipolar disorder, we start with first understanding how CBT can help. So these are some of the points that I have gathered through, understanding bipolar disorder, how we can help them with CBT. See, as I said, many clients are in denial because they are not aware of the symptoms. And even if they are aware, they don't know that this is bipolar 1 or this is bipolar 2. So first thing that CBT really helps is with psychoeducation. So understanding of symptoms, what to expect from my disorder. Like with my client, I remember whenever there was a manic episode, she used to feel more restless. So obviously restlessness is one of the symptoms, but that added restlessness that she used to experience was also due to not knowing what is happening with me. Why this kind of heightened mood is there. So remember something, understanding of symptoms, naming the symptoms is very important for our clients. That's why first thing is psychoeducation. Second, most important problem that I see with clients is non-adherence to medication. Non-compliance, I have seen that they would not follow up with psychiatrists. Sometimes I remember with one of my clients, she didn't even tell me that she's not taking the medication. Only when I had a session with the caregiver, I got to know that. So non-compliance is also very common. Obviously, here there are psychiatrists on our platform today. They are in a better position to address the reasons for non-adherence. But you can correct me if I'm wrong, the psychiatrist present on this panel. According to my knowledge, I have seen non-compliance also comes from the side effects that clients experience. And sometimes they would, like I have seen with some of my clients, they would develop this low tolerance for these side effects. And sometimes imaginary side effects also. By excessive reading, they would just think to themselves that this could be the side effect that I would experience. So that's very, very important. So 2 important points how CBT can help. One is with psychoeducation. Secondly is with adherence to medication. Third is management of other emotional issues. See, we looked at the symptomology here, but clients themselves, they go through other emotional issues like anxiety, not from a disorder point of view, I'm saying, but let's say from the point of view of distress. They have this constant anxiety about what next, what is going to happen with me now, how long these symptoms are going to persist. And anxiety also about their career related goals, What if I'm not able to have a more fulfilling career because of this disorder? So anxiety is very common, I have seen, right? Parvati says mainly the clients are worried about whether they would get addicted to medicines. Yeah, that is also one point that comes up. And Vibha says also very common belief that these meds are addictive. Yeah, same thought. Yes, true. So emotional issues, I was saying, anxiety is seen. Second, guilt. Inappropriate guilt, which is also one of the symptoms, but guilt, even distress oriented. I've seen with many of my clients that because there are so many follow-ups that they need to do with therapy and with consultation with psychiatrists, the financial load is also pretty high for management of bipolar disorder, and it is chronic. So I've seen many times investing in therapy, investing in consultation with a psychiatrist, they would also, like my client used to question this, that all the money is getting wasted in these treatment protocols, like so much of money I have to give to them. So I used to see in every session that this guilt is to add to her current distress. And also anger about not being able to live a more meaningful life. They also have goals, personal goals, academic goals, occupational goals, but they are not able to fulfill them. Also, one of the reasons are these symptoms also. They are pretty distressing. So CBT also helps with management of emotional issues like anger, anxiety, and guilt. I've also seen CBT treatment strategies or tools many times helps them with a structure. Understanding how to, at least they get some structure to see that probably there is some hope here. So it gives them some hope, it gives them some structure to their day. Especially with major depressive episodes, I have seen structure becomes key. And even with manic episode. Right? Some level of structure is important. And that CBT gives. Then CBT also helps with increasing awareness. Now, can you tell me here, awareness is with what? What kind of awareness are we looking at here?
Of what? Of
Symptom
what?
level awareness is there. Sorry.
Regarding with their issues, like what's going on within them, with respect to their thoughts, feelings, and other aspects.
Right. Most important is the emotional awareness also. So here we are not just looking at their symptoms, but also awareness in terms of what kind of emotions they are going through, what kind of thoughts they are going through. Awareness also regarding the different episodes that can come up. Awareness also regarding sometimes when the episode is not there, they are very functional. So awareness even regarding these functional episodes, right? Awareness also regarding how therapy works with bipolar. It's a bit different. Lot of trial and error we have to do with our clients when it comes to management of bipolar. Lot of trial and error. So CBT helps with this kind of awareness also. Then CBT also helps with developing an early warning system. I think probably this is the most effective features of CBT for bipolar, that we enable our clients to prepare their own early warning system. I'm going to talk about it a bit more in the coming slides. So early warning system is something like understanding what are their early symptoms and signs. Okay, so that is also pretty helpful. We have some comment. Triggers, yes. So we involve triggers here, but here mostly I'm looking at the symptoms of bipolar for my clients. Then CBT also helps them with self-blaming tendency. I've seen clients who go through bipolar disorder diagnosis, they are very self-critical. They are going through issues related to self-esteem, right? So working on self-blaming tendency through CBT, through cognitive restructuring is also something that helps our clients. And general adherence to overall treatment, not just to medication, but adherence to treatment from therapy point of view also. So overall adherence is also something that we keep focusing on. Because I've seen some clients like medication more than therapy, and there are some clients who like therapy more than medication. But we have to maintain a balance where both are equally important if we have to manage these symptoms. Okay. Yeah, self-pity, yes. Self-pity is seen sometimes as a defense, right? To deal with their own emotional distress. But actually the self-pity also comes from a lot of stigma related to bipolar, okay, to be very honest. I've seen families also having intense stigma related to bipolar. So I've seen many a times family members do not take the symptoms seriously. So like with my own client, when she was not able to follow a schedule during her manic episode, the family member used to be like, iska roj ka hai, you know, this is what she does always. So what you say, undermining the importance of the symptoms, and then that's why it triggers the client also to get into self-pity mode, where then they are going to be like, only I have to care for myself, only I have to be there for myself. So sometimes they can even get into attention-seeking behaviors then. Yeah, victim mode, right. So overall adherence to treatment is also what we will focus on. And interesting aspect about CBT is it also helps clients to anticipate roadblocks. What could be possible roadblocks in the treatment of bipolar disorder? Roadblocks coming from medication, roadblocks coming from sleep disturbances, roadblocks coming from nightmares, roadblocks coming from therapy engagement. So preparation and anticipation of these roadblocks is also something that can be pretty fruitful. And last important point is CBT also empowers the client to learn problem-solving techniques. What can be done if I am getting stuck with one of the issues, let's say with occupational concern? Some problem-solving steps are also discussed. And we help them with those skills, problem-solving techniques and skills. Okay, so do you have any questions on this slide? Do you have anything to add? Anyone who already practices CBT for bipolar disorder here? We can do a show of hands. Why I'm asking this question, because then if you have to add anything to this slide, please, you can do that and let me know. No one here who practices CBT for bipolar? Okay, Leon is there. Other than Leon, I'm not able to see anyone. Just going through all the okay. Now, So after we have understood how CBT can help, so it's a very, very helpful point for us, right? We are now going to look at the first important CBT model component. What is the component when it comes to working with bipolar? CBT, we start with understanding bipolar. So remember, now all these slides are related to our work with the clients. So when I say understanding bipolar disorder, this is not as a therapist. I have to make the client understand the disorder, what it is. Here start the CBT model for bipolar disorder. The first important point is helping clients understand and get education on bipolar disorder. We also call this socializing client to bipolar disorder. I have seen this as therapists, we do not spend more time in this. You know what CBT protocol says? At least 5 to 6 sessions you need to spend on this. At least 5 to 6. Obviously, we do cover other things also, but so much of understanding of the symptoms we need to give to our clients. So first understanding that I give is what is bipolar. So I actually sit with DSM-5 with them. Obviously not with a technical language, but you can just do a quick symptom monitoring. You can just prepare a quick symptom monitoring sheet for your clients. Let's say they are going through bipolar 1. So then manic episode, all the symptoms you could write down, right? Hypomanic episode, major depressive episode. You can see generally which episode they are in, right? And then you can educate them about each symptom. And then I have also seen what I do with them is, let's say one symptom is lack of interest in what I used to find pleasurable, then we can have a discussion on it. So in your experience, so you can ask your client, in your experience, where do you see this symptom coming up? Can you give me one example from your own life? I think discussion on each symptom is very important because only then they will apply that to their own life. And that will increase awareness. That will increase their recall also, that next time this happens, they will be alert. Okay, probably this is an early sign. I have to report it to the psychiatrist and to the therapist. So please don't look at it like, okay, just we have to make them understand. No, this is not like that. You have to do in-depth understanding. Each symptom, give examples, try to elicit examples from their own life, right? You can even create a therapy log for that. Obviously, to be very honest, therapy journaling becomes a bit difficult with bipolar disorder clients I've seen because the motivation is generally a bit low. That's why I prefer information worksheets. I have actually gone and created some, I have researched on some worksheets and I'm going to share those worksheets also with all of you. So what is bipolar through worksheets is going to be very, very helpful. Right? So I have one worksheet which talks about, in short, what is bipolar and some symptoms. I will share that with you. Please go through it today. And tomorrow, before coming to class, if you have any questions, you can note it down. So first I start with what is bipolar, then what causes bipolar. Because I have seen many a times, I don't know whether you have observed, but clients are like, oh, it's all in the genetics, right? So why should I work? Either that approach is taken or blame my parents, blame my childhood, blame my interpersonal traumatic events. So when we are actually looking at causes of bipolar, I really like one worksheet because that worksheet talks about what are different contributing factors for the maintenance of this disorder, for the development of this disorder. Right? So we are going to look at that. I'm just going to share my screen again with the worksheet which I use for causes of bipolar, okay? Ignore the highlights here in the worksheet because, I already have highlighted points for my clients, but it would be actually beneficial for all of you, I guess. So this is what causes bipolar. So go through it later in depth, but basically we are talking about genetic vulnerability, biological vulnerability, different stressful situations of life, There are so many risk factors which will maintain, and some protective factors are also there, which if we develop, we will be able to manage the disorder. So we start with genetic vulnerability here. It runs in families also, especially first degree relatives, right? Then biological vulnerability where biochemical imbalances are there. Then you see life stress, like different stressful events that clients have gone through, family conflicts, employment related difficulties, dealing with grief. Inability to deal with grief is also very common. And then I highlight that just because someone has a higher genetic vulnerability, that does not mean they will develop bipolar. Also, all these contributory factors you have to see together. Their interrelationship also you have to see. From therapy point of view, please focus more on coping. Because if you focus more on just genetic and biological vulnerability, I've seen clients are like, then, they might just be like, okay, so why are we even doing therapy? Let me just take medication. So please highlight the importance of learning coping strategies to manage stress, building protective factors to manage bipolar disorder, right? So protective factors are good coping strategies, are coping strategies that you can use today to manage your disorder and live with that disorder with healthy disturbance. I make this point very clear to my clients that elimination may not be the goal. The goal is management only in CBT. So don't look at eliminating symptoms. So are you saying with CBT, I will have no symptoms of bipolar? It will completely go out of my life? No, that is not what we are saying. We are looking at management of these symptoms, where how they can live with healthy disturbance, with healthy, distress. So protective factors also here, I like this worksheet because they have even highlighted some protective factors like good social support, building your communication skills, problem solving skills, seeking help, right? Building your other family support also, having a more balanced lifestyle. All these are coping factors that we are going to work on. So this is a very nice worksheet to what causes bipolar disorder. Obviously, this will be shared with you, so you don't have to worry, and you can then later go through it. So what are we, just a quick recap that we are right now talking about CBT model for bipolar disorder. It starts only with psychoeducation, where we are helping them understand their symptoms in much detail, right? And sometimes, I've also given some homeworks to my clients where in the next session when they come, I tell them, now tell me what are the symptoms of bipolar 1. Can you give me examples from your own life scenarios? So you can even have such kind of homework assignments where they themselves will think and they are going to come back to you. So you will be more clear whether your client has actually understood these symptoms. Remember something, homework in CBT starts from session 1 only. So I have seen like many of my clients, they are, as I discussed earlier, they are less motivated to maintain therapy journals. But in the session, whatever homework is possible, please give them that and check it within the session only. This is a trick that we have to use with these clients, that in the session only 15 minutes, give them some homework in front of you. Okay, please go through, like I have given homework, like go through this worksheet right now, which I showed you what causes bipolar disorder. I make it a point that I give them in the session only to go through it in front of me. So let's take 15 minutes, please read this worksheet, then let's have a discussion. So psychoeducation is also happening and the homework assignment is also happening in the session. Because there is denial, I am doing this. I don't do this for my other clients. Yeah, we can ask clients to record their thoughts too. Yes, Leon, you can do that. Therapy, in therapy, thought records can be used. And I think I've mentioned quite a few times when I come to these workshops that I use a lot of online journaling with my clients. So with some of my clients who are going through bipolar disorder, online journaling really works because, again, confidentiality, only they share the password with me. and that space, they someone else looking at their diary and reading all that is not a problem. So I use the Penzu app. I think I've discussed in my previous sessions. Some of you have been a part of it. So Penzu app is something that I use. It's a very nice app. So I'm just typing it down. You can just search it on Google later. So are we clear? Any questions till here? If you have, you can ask me. Let's go ahead. So what is bipolar? Then what causes bipolar? Then early signs worksheet. This is most important. So early signs means how to early detect. What are some early signs? I have realized one thing. For each client, early signs are different. So let's say for my client who's going through bipolar, for one client, the early sign can be distractibility. For another client, it could be flight of ideas. So detecting these early warning signs is a bit tricky at times. So you have to really talk to your clients and see what their early signs are. But I also follow one very simple worksheet for early signs. I'm again sharing my screen for that. Detecting early warning signs. So I tell them why we are detecting early warning signs. Can someone tell me here, why are we focusing on detecting early warning signs? What is the first motive? Anyone?
So that they know that, things may get more severe. So if they can control it, cope with it when it's just starting out, that would be useful.
Okay, one for probably management, as you were saying, if things get severe, they can now only manage. Okay, that's good. What else?
I think seek treatment, go to the psychiatrist.
This is most important, going to the psychiatrist, because they will delay that a lot. And the more you delay your appointment with psychiatrist, you will have an appointment with disappointment. Right? Because then there will be intensified symptoms. So going to the psychiatrist and the therapist, right? Early cure, yes. And I've also seen, once they are able to identify these early warning signs, okay, some sense of agency they get, which is good for their confidence. So in a way, this detecting early warning signs can also help them with their confidence and with their hope to manage this chronic condition. Thirdly, when they are able to identify these warning signs, okay, if you have already discussed coping strategies, they can use them. If they know that the early sign is decreased sleep, and if the psychiatrist has told them, oh, this is the SOS medication, they will take the SOS then. Right? So coping tools also they will use only if they know what are their early warning signs. So this worksheet talks about first, why we are looking at early warning signs, why we have to understand them, and what are the different early warning signs. So there are some common they have given here: increased activity, decreased need for sleep, elevated mood. Like with my client, I used to always tell her, share your calendar with me. Share your Google Calendar with me. And so that I will understand what all she's keeping in her Google Calendar. How many tasks are there? Is it like filled with tasks? It would also be good for my understanding. And I can also help with the early sign, catching the early sign. So increased activity, decreased need for sleep, right? This is for mania. For depressed episode, you will see again loss of energy, too much of tiredness, not wanting to meet people when you're canceling plans. You're just going on canceling plans, right? Without any objective reason for it. Loss of interest in meeting people, loss of interest in pursuing your hobbies, in pursuing your own goals that you had probably decided for yourself, increased issues with focus and concentration, thoughts of self-harm, thoughts of death. This is very important. Leon, I think I've covered this point. Psychotic features are only a part of bipolar 1, not a part of bipolar 2. Psychotic features like hallucinations and delusions. Right? So these are very important early warning signs. And again, with clients, what I also do is, in this worksheet also you will see, these are very good 2 questions that you can use to understand their early warning signs. So you can ask your clients what you are when your mood is mildly elevated and moderately elevated. How do you look to yourself? Let's say your mood is mildly elevated, then what kind of behaviors you get into? And let's say if your mood is moderately elevated, then what kind of behaviors you get into? Same thing with depressive episode also. Let's say if you are mildly depressed, then what are the behaviors? And let's say if you are moderately depressed, then what are the behaviors? And keeping a log of these behaviors can be very essential, because then clients are able to probably keep a note of their behaviors also. Am I going through any of these behaviors right now? Do I have to, alert the psychiatrist? Like with my client, I remember with her major depressive episode, 3 behaviors were most common. Excessive sleepiness. Every answer to a concern is to sleep. So that was one major warning sign. Second was when she used to cancel plans without giving any there was no objective reason for doing it. Just not feeling like it. Right? And third is thoughts about hopelessness thoughts, where she used to question the very, core of her philosophy, core of her goals. Why did I even take up this assignment? So such kind of thoughts used to be her early warning signs. And then what you can also do on the basis of your client's own early warning signs, you can create coping tools also. Right? So if there are intensive hopelessness thoughts, then the coping strategy could be, please note them down and share with the therapist. This is what we had prepared for her. Note these thoughts down, share it with your therapist. If there is excessive sleepiness, call your, book an appointment with your psychiatrist. Notify your therapist and your psychiatrist immediately. And sometimes I have seen, like with my client, she had this guilt to even message me or the psychiatrist. So we devised one plan where the family member will notice these symptoms and they will be in touch with me for any kind of such messages. I remember whenever she used to also cancel sessions, by the way, which is also one of the signs, unfortunately. And I remember we had made a plan for that even if you cancel a session, I want your mother to update me on your status. So her mother used to update me that she is canceling session under this kind of a context right now. So develop coping strategy for each early warning sign if it's possible. And this could be a great action plan. Right? So a 2-column technique. Document. You have to give them that feedback on the document. If the coping tools are healthy, the coping tools should not be unhealthy and harmful. Right? Let's say loss of interest. If the client is having then excessive smoking, it should not be unhealthy coping tools. We are only looking at healthy and functional coping tools here. So till now we have looked at 3 factors. Again, I'm saying that we have already started with the CBT model for bipolar disorder, where the first component is to socialize clients regarding bipolar disorder, where first we saw giving them in-depth understanding and eliciting their real life examples about the symptoms that they observe. Giving them good knowledge about these symptoms through DSM-5. Second, we looked at what are the causes of bipolar disorder. We looked at a worksheet. And third, we are looking at importance of detecting early warning signs. Any questions still here? Yeah, Dr.
Suppose
Pooja,
they are
yes.
staying alone and they don't have anyone to detect it, or they themselves are too confused to, admit it to themselves, or they're defensive about their symptoms. In such a case, as therapist, what can we do?
It's a very difficult state for the client to be in. If there is lack of social support, I think it becomes again very difficult for us to help them be in therapy and be in treatment. So I would suggest in this cases, you can again try your level best to do, like, probably at least what I do generally is weekly follow-ups with my clients who are going through this disorder. I think I would follow up with them more than with other clients. I've also done something like where first session has happened, like let's say first session happened today. Within 4 days, I've sent them a follow-up message. Can you please update me with your symptoms? How are you doing? When should we schedule the next appointment? This I may not do for my other clients, but if I see that there is no support that they have, and sometimes, the family members are not ready to engage in treatment because of whatever reasons, financial reasons also I have seen, stigma is also another reason. So then that becomes again very difficult. So from a therapist point of view, I think I would say follow up with them more. Follow up, create a very good follow-up system, either through email, through WhatsApp, or also have check-in forms. With my practice, I have seen, like, from my last year practice, my client only gave me this feedback that why don't you have a self check-in form for your clients? So I created a self check-in form for all my clients. So whoever are in therapy with me, whether they are going through any kind of diagnosis, even if there is no mental health condition, only distress, they have to fill that self check-in form weekly. So that self check-in form also helps me to see what are their present symptoms. And there are many questions on that form. Have you had, when was your last appointment with your psychiatrist? What are your, are there any changes in the medication? What is your feedback on our therapy session? So I get a nice overview about what they are thinking. How likely you are to book the next therapy appointment? This is also one of the questions that we have purposely added there. Right? So I think I have answered your question in brief. Now, in understanding of bipolar disorder, self check-in form, Parvati, I will see if I can send it. I have to think on that. I cannot give a direct yes or no answer right now. So next psychoeducation we do is on treatment available. What is the treatment that's available for our clients? Because sometimes, they think that therapy just doesn't work. And I find it I don't find it surprising, because many a times some mental health professionals also don't promote therapy for bipolar. It's like, I don't think therapy, what is therapy going to do with these kind of symptoms? Some mental health professionals also have this kind of blocks. So in treatment available point, actually I'm trying to tell them that there is something called as CBT, which is evidence-based therapy. And definitely we cannot eliminate your symptoms, or you're not going to feel good all the time, but management is possible. So giving them a very good understanding about what is CBT, how it can help them. So you remember the first slide that I discussed. Someone is not on mute. Can you please mute yourself? Yeah, thank you. Okay, sorry. So, I was saying that how CBT can help. You remember that one slide that I shared with all of you, how CBT can be helpful. You can actually go through that slide with your clients so that they understand that there is something that's going to help them. I have used that slide with my clients. So this is the point regarding treatment availability for management of bipolar disorder. And the next point for this section is educating family members about. So I even educate family members through all these worksheets. What is bipolar? What causes bipolar? Early signs, which I'm doing with the client. I also have an individual session with family members, the same session, where I'm also helping them understand these symptoms and getting their understanding also. And I also tell family members that I would need your involvement in the treatment. Otherwise, treatment is not going to be that helpful because dropout is high with these clients, very high. Dropout even from medication treatment and from psychotherapy treatment, both is high. So to be very honest, without some support system, it gets very difficult to maintain them in treatment. So I give them this understanding, and then I also would discuss with family members that can you monitor their mood and symptoms for me? Can you keep a check on their mood and symptoms? Because then they can also detect early signs and contact me, right? Let's say if the patient is not able to do, but the caregivers can do it, and that can really save the patient from so many mental health conflicts. And I'll be better prepared as a therapist, and the psychiatrist also can plan treatment accordingly. So there is one worksheet I use for monitoring mood and symptoms even for the family members, which I can help you understand what is it. Just trying to share that worksheet. So it is more like a simple symptom monitoring PDF. Obviously, all symptoms are not covered here, but at least to start with, this is good. As I said, you are free to even create your own worksheets, okay? This is just as a, sample, but you can create your own. So this is a symptom monitoring form where, some symptoms are given here. Mix of mania and depressive episode. So depressed episode, loss of interest, increase or decrease in appetite, unable to sleep, sleeping too much, fatigue or loss of energy, racing thoughts, more talkative than usual, easily distracted. So, they can actually give you a weekly understanding of their symptoms through this symptom monitoring form. So every time your client comes for the session, before they enter your session, you already have this form from the caregivers. Sometimes I've had caregivers telling me, we can't fill these forms, can we send you voice notes? So I'm like, fine, because they don't find this practical. That also I'll tell you. Some caregivers have come up to me and they're like, we don't have so much time to invest in this. In spite of telling them how helpful it will be, sometimes they may not invest their time into it. So then come up with alternatives. You can come up with alternatives like voice messages, WhatsApp messages, just writing a note to the therapist. That could be quicker for some. So family members who are interested and who are wanting to invest through these symptom monitoring sheets, you can give them that. Otherwise, other mechanisms you will have to use. Are you clear? Sometimes what you can also do is, you remember how I said in the initial point that early warning signs you can create for your client together. So that list only you can give to your caregivers, and they can use that list to monitor. Let's say if they observe one of the symptoms from that list, that personalized list, they can contact you. Okay. But again, I'm adding one point that irrespective of early detection, please have them give you a weekly follow-up. Caregivers or family members, even if they are not coming for therapy sessions, please tell them to give you weekly follow-ups about your client. I have seen that is very, very helpful. Okay, so this is also one worksheet that I can share with you later. So I think here till now we have covered the first component, the first part of CBT model for bipolar disorder, which is socializing the client regarding this disorder and involving family members. So here only, because we are already talking about helping them monitor their symptoms, I also discuss with family members what is their role in the treatment for bipolar disorder. So that's my next slide for all of you. The role of family in the treatment plan. Because sometimes clients are also not, family members are also not very clear. So I tell them first is relapse prevention to prevent significant disturbing relapses. Because one of the major reasons to why a relapse happens is monitoring is not there. Daily, weekly monitoring is missing. Monitoring of symptoms and monitoring of coping tools, whether the client is using coping tools, whether the client is following a routine, no such monitoring is available. So sometimes the client is not in the state to do, I understand, but family members, definitely they can help us. So that's why, first with relapse prevention. Second, if family members have a good understanding of the disorder, they will also help the client in understanding the symptoms, in not blaming themselves. Sometimes family members also blame the client because they are not aware of the symptom. Or sometimes they are aware, but they don't remember that I have to think of my, let's say my daughter or my mother from this lens. So empathetic understanding of your client, of the the client can only happen if the family member knows the disorder in depth. That's why psychoeducating family members on the disorder, helping them understand what causes bipolar, how medication is going to help. I have had some family members only telling me, he's not going to continue with medication, it is our decision. Like one of my clients, one family member only told me this, that I don't think we will again go to any psychiatrist. So when I asked why, side effects. Right? We just don't want to, the weight gain is just too much. Iski shaadi nahi hogi. Like this is exactly what they said. And obviously, they probably did not have an understanding how important is medication for the treatment. Without medication, therapy is not going to work. It will be completely counterproductive. So I have had sessions where I have discussed with them the role of medication with the psychiatrist, because the psychiatrists, they have better knowledge about the role of medication. So I would prefer sit with the psychiatrist for that session. You can handle the therapeutic understanding of medication. Right? So this is important. Adherence to medication, you have to even tell the family members. Then helping them also communicate better with the client, how they can effectively communicate with the client, what kind of communication techniques they could use, what not to say. How to talk to the client is very important, because sometimes they are so agitated. They're so much in a restless state of mind that they're not able to understand or take feedback, take constructive feedback. I've seen with clients who go through major depressive episode also, sometimes the constructive criticism is no more constructive for them. It is highly destructive, because they are also getting into a lot of worthless core beliefs. Those worthless core beliefs get activated, and then the client will not be able to take the feedback objectively. So then how these family members are communicating feedback. So then that's why importance of communication skills. Then what family members can do during intense episodes? Do they have contacts of rehabilitations? Do they have contacts of good hospitals? Do they have contacts of the psychiatrist and the therapist? Right? So what family members can do during intense episodes? How they should not get unhealthily anxious if there is an intense episode. If a client is sharing thoughts about self-harm, how they are supposed to react. What should be the home environment? Right? All these things will come under family psychoeducation. And then supportive therapy. Supportive therapy is basically using some supportive techniques for your client. Like I remember in a few family therapy sessions, we actually had to focus on I messages, teach I messages. As a therapist, you need to teach I messages to parents and to other caregivers. Do not use you messages. Like I remember with one of my clients, she shared an episode. One night, she did not sleep on time. Generally, consistent sleeping time, if it is there, it helps our clients who are going through bipolar. So I remember this is what we had discussed even in a family therapy session. And one night she extended her time because she went for a movie. And unfortunately, she did not think that this movie is going to take so much time. She came home only at 2 a.m. or something. And I remember this family member, because he was psychoeducated on it, she just slammed the client that how can you do this? You need to have consistent sleep time. Now you're sleeping at 2 a.m. Again, your symptoms are going to show up. Now, this is not being supportive. So supportive is again how you can discuss this feedback. Using I statements, using a bit kind words while talking to the client, informing this to the therapist rather than you directly handling it by yourself. Probably you could schedule a session with the therapist and talk about this concern. Understand that this could be probably a mistake on her part, having a discussion on it rather than a judgment on it. So such kind of techniques will come under supportive techniques. So which obviously the therapist has to teach. And then again, we have covered this point that early signs, even the family members need to be thoroughly educated on the early signs so that interventions can happen quicker. Are you clear? So we started with socializing the client about bipolar disorder, then even socializing the family members about the bipolar disorder in depth and explaining them the role of family. And sometimes the same slide you have to use even with clients because clients are not ready to involve family members at times. I've also seen this happening, that the family members are wanting to be a part of the treatment, but client doesn't want. Because some clients have told me if they become a part of treatment, then they will have lot of, they'll be watching me all the time. I don't want that. My independence will be snatched away from me. So then I have to do a lot of work with this client also to educate that if you come to treatment individually, it's not going to be that effective. Right? So these are some important points. Are we on the same page? I hope you are with me because that no one is asking any question and most of you are not on your video. So if you are sleeping, there's no way to know here. Thanks to Dr. Pooja, she is there. So I'm just looking at her. But yeah, I saw Dr. Marino also coming here. So Leon has a question. Does substance abuse and BPD feed each other? Yeah, yes, that's true. Comorbidity with substance use is highest, most commonly seen. So definitely there is unhealthy coping strategy of alcohol use, substance use that is employed by some clients. Then it becomes very, very difficult. But then sometimes I've seen with comorbidity, you have to first handle the comorbidity. Right? Immediately that handling is necessary. Again, with medication and with psychotherapy. So again, Leon, here I would tell you one thing, that involving family members, that's why then it is very important, because sometimes the family environments are very empathetic, and they are validating the concerns of the client. I have seen progression is good. Very good recovery progress happens with that empathetic and that unconditionally, that unconditional environment. If that we are able to provide to the client, nothing like it, it's going to be very important. So again, I will refer to Carl Rogers here. These three conditions for family members are also necessary. Unconditional positive regard of your client, then being empathetic towards them, being very, very empathetic towards them, and congruence. You are genuine. You actually want to help the client. So the family member should adopt an approach that I want to really help. That's why I want to be in treatment. It's not that you want to, observe them or you want to really blame them for their issues. Okay. So should we go ahead? Now, quickly, I'm going to look at intake interview. Okay, if you are doing an intake interview, not all the therapists would do intake interviews, so that's fine. But if you are doing it, then what kind of pointers you can look at? Again, from CBT point of view, I'm addressing this point. Okay. So this could be done in the first session also. Right now, I'm talking about first few sessions only. So this could be done in the first session, or this could be done before they are coming. Like you can even create a form using this intake interview, like a Google form that they have to fill before they enter your therapy setting. So you already have it, whatever suits you. But I would say interview style is preferred. It's much preferred here. So what are these points? So onset of illness, when did it begin? Do they remember? This intake interview we can also do with family members. So what was the onset like? What were the stressors during onset? Was there any stressor? So I've seen with my client, loss of a loved one was a big stressor there. Loss of a pet and loss of her grandmother happened at the same time. And I know with my client, she did not have skills to cope with grief. Her grieving skills were very, very unhealthy. And those were also reinforced by parents and family members and relatives. So where she went on suppressing her emotions. So onset of illness, what are the stressors during onset that you saw? Then medication history, has she ever been on medication for bipolar? If yes, how was her compliance? Was she following up with the psychiatrist? Follow-ups were there? How often she used to follow up? Was there any time when she did not take the medication? Has she missed taking her medication? If yes, what were the possible reasons? And if they have not taken medication at all, then again discussing what were the reasons for not taking medication till now. What came in the way? Then next is very important from CBT point of view. What meaning they are giving to their diagnosis? Now that my client has got a diagnosis of bipolar disorder 1, let's say, what is the meaning my client is giving to this diagnosis? My client used to say something like, it is disability. You know, so definitely it can feel like one, but what meaning are you giving? And I remember many a time she used to feel very hopeless even about therapy. That how are you going to help me? How are you going to help me with these symptoms? How is anyone going to help me with these symptoms? And because she lost a lot of relationships during her episodes, those had some consequences. Her episodes had very, very difficult consequences. Lot of meaning that she gave to the disorder was hopeless. This is a hopeless case. That's what she used to say to me. So please elicit what meaning they are giving to the diagnosis. We have to work on that. Then what is their level of understanding of the diagnosis? What do they know about bipolar disorder? What is their understanding? Check their level of understanding in terms of symptoms, in terms of what to expect. And also check their understanding in terms of treatment availability, and then acceptance. On a scale of 0 to 100, how much are they accepting this disorder? What kind of acceptance do they have? If they have very, very lower acceptance, then again, we have to work on that aspect. We have to educate them about it, and we have to see if it is too low, then first we will have to work on helping them accept the diagnosis, which I think is the major concern with our clients. So onset of illness, what were the stressor points, medication history, compliance, what meaning they are giving to the diagnosis, what is their level of understanding and acceptance, what are their current coping styles? Currently, how are they managing their symptoms? Like with my client, when she entered therapy, her current coping style was excessive smoking and taking on so many projects, like working at 4 or 5 different places at the same time, which was not even realistic. So her coping styles were smoking, then overcompensation, right? What other coping styles we can see with our clients? Unhealthy. I've also seen excessive, like social media addiction also is something I've seen. Yeah, binge watching. That is also very commonly seen. Then sleeping, excessive sleeping. So I would say note down their current coping styles. What are these current coping styles that your clients, they are using today? Can spending behavior come under this? Yes, excessive spending, right? Their shopping list. I remember when I used to work at a rehab, sometimes on the file, we also used to ask them to put their, shopping history, monthly shopping expenses. Those also sometimes we need to take into consideration. How are they how are they using their money? Monthly expenses also you need to check at times. So that's a good point actually. So current coping styles. Then what is their general self-talk? How do they talk to themselves generally? So I ask them things like, when you start your day, how do you talk to yourself at the start of your day? What kind of dialogue do you use with yourself? So this is basically trying to understand their thought patterns. Yeah, flight of ideas, racing thoughts, if they are present. But we are also looking at negative thought content here, or grandiose thought content. I should get all the attention today. I deserve this kind of attention. Because there is also grandiose delusions which are present in bipolar 1. This thought content will even help you understand if there is grandiosity, if there is overly critical self-talk, if there are continuous ideas that are coming in their mind. I have had client telling me, I remember when I told her to maintain a therapy log, I remember the document were it was on 20 pages, 25 pages. So this is again flight of ideas, right? So that also helps you. How they write their therapy logs, that also will tell you a lot about your clients, current state of mind. So thought components. Then what is their general social, occupational and interpersonal functioning? Are they going out? How often? Like with my client, because obviously she had a diagnosis of bipolar 1, her going out was excessive. So too much socialization is happening, excessive socialization at the cost of health, at the cost of sleep. Very, very important point. Then occupational, how is their occupational productivity like? What kind of feedback their colleagues are giving them? Right? What kind of feedback supervisor is giving? So sometimes this caregiver can help you understand in a much better way. So are there any occupational deficits? Have they, do you see that they are not going to work? They are just canceling offline work. They just want to take work from home. I've seen this happening during COVID time, that once things went back to normal and you now have to go offline and work. Some clients just still wanted to choose online working. So look at that. What is the reason for that? Then interpersonal functioning, romantic relationships, what's the status? How often our patients are asking for help? How often they are sharing their feelings? Like with my clients, she used to just not share her feelings with anyone. Complete suppression and avoidance of her feelings. So again, that's going to be pretty critical for us. Then what is their existing support from the family? How supportive is family? Is family participating in therapy? Simple thing like, after therapy session, does any family member message the therapist? How was the session? Please update. Do they ask for update? And if they do, is it consistent? Do they come for your follow-up sessions for family therapy? Do they come for follow-up? All these points are going to be important. And how invested family members are in the disorder management also. Do they help the client to buy medicines? Do they keep a check on the client's medication? Is my client taking medication on time? Or is my client missing medication? I've seen with one of my clients, the family members had no idea what medication she is on. They didn't even keep a record of whether she, buys this medication. Is she refilling these medications? It's going to be again important. Then what are my client's hobbies? Is he engaging in some hobbies, some interests, some pleasurable activities, some recreational activities? Is it too excessive or nothing? Or is there a balance? You need to check this also. Like in major depressive episode, you will see it's not there at all. And in mania, you would see it is excessive. Then what are my client's goal for self? Does she have any goals for her own self? Academic goals, career related goals? What kind of goals are there? Just give me a minute. I just need to put my laptop on charge. Just a minute. Okay, I'm really sorry for this interruptions. My laptop just went on sleep mode. So where were we?
Goals for self.
Right. Yes. So talking about what are the goals, my client is having for her own self. So basically here we are looking at not just their goals related to therapy, but we are also looking at their personal goals from life. Like I have had clients telling me that I also wanted to get married. I also want to be in a relationship. Right. So these goals are also important for us to remember and include them in our understanding, because they will motivate the client to be in therapy, I've realized. So the moment they express these goals for self, it's a very good point for us that probably these are the reasons to why they want to work in therapy. And if there are no goals from self, then from a therapist point of view, somewhere we have to work on this concern. Somewhere we have to probably motivate them to think about what are their goals other than, bipolar disorder. Because sometimes, they get so entangled with the diagnosis. We cannot blame them, obviously, because it is very chronic and intense, that they are not able to think of their goals other than treatment. Other than management of symptoms, they are not able to think of other goals. So then this becomes like with my client, for her, companionship was very important. Love and intimacy was very important for her. So this point came during our discussion for goal for self, that she wants to get married. She has that goal in mind. So anytime, when she used to feel very, very hopeless, this point was working for us to at least get her hopes 5% high, 5% up. Are you getting me? This is the point that we were on, goals for self. Then next was, last 2 points remaining. Next was recent consultation with psychiatrist. When was the last consultation with the psychiatrist? What was discussed in it? Medications were added, reduced, what happened? And this recent consultation also tells me the follow-up pattern. Is it very haphazard? Like with some clients, I've seen the follow-up pattern is based on the episode. If the episode becomes intense, then they will immediately follow up. Otherwise, there is no follow-up at all with the therapist also and with the psychiatrist also. So if there is haphazard follow-up, this question is going to help you with that. If there is no understanding about the importance of follow-up, then that also you can work on here. Like sometimes I've had clients telling me, no, my psychiatrist said meet me after 2 months. So then why should I follow up? Then is there any need to follow up? So then I tell them that generally they will say that meet after 1 month, meet after 2 months. But from a patient's perspective, it's important for you to follow up. Because only if you follow up, they will come to know that there is some emergency, that there are some changes in the symptoms. Otherwise, they are not going to come to know that. So such detailing work is needed with our clients. And lastly, what kind of diet do they follow? Are they having meals on time? Are they excessively getting into eating? Because I have seen in bipolar 1, sometimes the unhealthy coping strategy can be excessive emotional eating. Or it could be no appetite, lack of appetite. So look at what kind of diet do they follow. And also in terms of sleep, what are their sleep patterns? What time do they generally sleep? Before the onset, how was their sleep pattern? You can even have a nice comparison probably, so that where you will get a very good understanding about, the intensity of the disorder also. So here you can talk about what time do they sleep, how many hours of sleep do they need, like generally what is their, what time do they get up, is sleep disturbed, right? Do they, are they spending a lot of time in getting sleep? Are they not getting sleep on time? Is it delayed? What kind of problems do you see in their sleep patterns? Yeah, I think, Swati, I'm back now. Now probably you can hear me. Okay, so are we clear till here? So this is some questions in terms of intake interview. Okay. So till now, from CBT for bipolar perspective, we have discussed the first component, which is socializing them about bipolar disorder, right? Then we discussed role of family and how you can even help clients understand the role of family. We even discussed that. And the third important point that we are looking at was intake interview. Dr. Pooja, do you have any question?
Yeah, so I was going to ask about, if the doctor has already prescribed them some sedatives, then the sleep pattern is something that we won't be really able to understand, because then obviously they'll be just sedated.
Right. That's true. So that becomes another problem also here, that then we are not able to really clearly understand their sleep pattern. So I think you can take some inputs from the doctor also to understand how what will be the sleep pattern like of your client, and see if it is matching that. If it is matching that, then you can't do anything. But if it is not matching that, and if it's something very unusual, then you can work on it. And I think sometimes, adjusting to the sleep pattern is also something that we work on, Dr. Pooja. So here, when we are taking intake interview on sleep, not necessarily we are looking at management of that pattern, but sometimes even accepting that with this medication, this is what I will, be like. Because sometimes that acceptance of a side effect is also very critical. We are going to see that point ahead, but just one thing from what you wanted to share, this one part. Any other question anyone has? Okay. Now, this is next important. So first was understanding bipolar. Second was your role of family. Third was intake interview. Fourth is management of non-adherence to medication. If you see clients are not taking medication, they're not following up with medication, what all strategies you could use here from a therapist point of view? I've seen this to be, some of these could be very helpful. First is you have to understand the client's meaning of getting diagnosed with bipolar disorder. As I told all of you initially also in the intake interview, we asked them, what is the meaning that you're giving to the disorder? I asked them, the reason for non-adherence also sometimes is they look at the disorder as impairment, complete impairment. So nothing is going to help me. So what I do here is I elicit the meaning my client is giving to the disorder and see if it has got anything to do with their non-adherence. I check. So I ask them something like, so when you think that this is a hopeless case and it's a complete impairment, does this thought bother you to that extent that you feel like giving up on medication also? And generally they say yes. Right? So then in the very initial stage only, I would highlight this to them, that the meaning you give to disorder is what is maintaining your problem here. So you have to do a lot of, obviously you have to validate the intensity of the disorder, the distress that comes with the symptoms. At each and every point, we are going to remember Carl Rogers and all the skills that he has taught us: reflective listening, active listening, empathy, unconditional positive regard, acknowledging their distress, being empathetic. Using all these micro-counseling skills, I will tell them, but the meaning that you're giving to the disorder, if you look at this disorder as a hopeless case, then now I know why you don't want to take medication and why you don't want to come to therapy. This is nothing but the cognitive model in CBT. That what you think about the trigger influences your reactions. So I will highlight in a very simple way this cognitive model of CBT at the very start of my sessions. I've had clients telling me this, it's very easy for you to say all this. You don't understand the symptoms, they are very intense, because they are intense and sometimes it is so unpredictable, those symptoms. So what has worked with me is roll with the resistance. If the resistance comes, acknowledge the resistance as normal. Don't go on convincing them. No, but you know what? Still, how you think? Don't go on convincing them right now. Right now, please roll with the resistance by acknowledging that, yes, probably as a therapist, I might have studied bipolar disorder, but yes, I have not been through one. So maybe exactly I don't know what you are going through, but I'm still trying my best to understand. And I also tell them, okay, right now you may not agree with this model completely, it's fine. But can we keep it in our mind that this is something that is happening, the meaning that I'm giving to the disorder? This is called as rolling with the resistance. Because resistance is very common and it's a normal part in bipolar. Are you clear? Sometimes I've also given them my own client examples who are doing okay with this disorder. Sometimes, if I see that readiness coming from my client, if they are ready to listen to this cognitive model, then I have also shared certain instances of my own clients. And let me tell you, that kind of disclosure has actually helped many a times. Sharing such kind of stories, and not like success, I don't call them success stories, but I call them management stories. Stories where they are living with healthy distress. Stories where they are feeling annoyed that why did I get this disorder, but at the same time, they are trying to live. They are trying to look ahead. So sharing stories of your client examples, if you have, that can be very helpful. Remember, do not be highly optimistic and positive here. That is not going to be taken healthily. Just be very normal. Just be human and just be genuine. So don't be like, I have seen amazing case results, avoid words like amazing, because sometimes, that can actually induce more kind of, racing thoughts. It can even get them into more excitement, which actually is not going to be pretty helpful. So if your therapy session is also too exciting, I have seen it can be a bit counterproductive. So keep the session balanced. The tone of voice of a therapist also is actually very important when it comes to handling these patients. Anyway, I'm not going to that aspect right now. But this is one point. Second, significance of medication and regular follow-up. I have covered this point, so I'm not going to talk much about it. Again, helping them understand the role of medication, sit with a psychiatrist, have lot of sessions with you and psychiatrist together for role of medication. That has given more weightage, I have realized. Then addressing side effects. This also have a session with psychiatrist. Whatever side effects, I have told my clients, you are irritated about side effects, right? Okay, I completely get it. Just let's make a list of all the side effects that you're getting bothered by. Make an exhaustive list with them and tell them, okay, let's now have a session with the psychiatrist. Can we just do some problem solving on these side effects? And this has really worked, because then they are able to think beyond the side effects, because problem solving is also part of side effect management, sorry. So if the side effect is weight gain, what could be problem solving strategies? Can I start some exercise routine? Can I focus on my diet? Can the psychiatrist help me with some other medication, some alternative option here? And I've seen this, even if the psychiatrist cannot create an alternative option for medication, but the psychiatrist is ready to listen to their concern, that itself has motivated them. Sometimes they're looking for that validation, that yes, from the psychiatrist also they're looking, for this validation that yes, you are right, there is this very irritating side effect. I get it. So this is important. Addressing side effects, creating coping tools for each side effect if you can. If you cannot, then just acknowledging that, sorry, but this is going to be a part of our plan. This will come with the plan. That's where we talk about increasing their tolerance for these side effects. Some side effects you can't do anything about. They will be there. Then accepting these side effects as a part of our recovery process. So here I use a lot of acceptance and commitment therapy tools also for, accepting and willingness, that sometimes you just can't, you cannot solve a problem. The only way to solve a problem at times is to accept that this problem will remain. Powerful, but important. And also very difficult to digest, but again, very important. So I would help them with accepting some side effects, that they will be a part. We cannot do anything about them, sadly. But I've also seen this. Sometimes I psychoeducate my clients and I tell them that if you keep thinking about why can't we do anything, you will get more irritated and it will increase your anger. But a better option here is to be irritated healthily and to look at other aspects of your life. So let's say probably you're not getting sleep, but other aspects are there. Maybe you're not getting sleep at night, but because of that, you started reading something. Right? So this is something that will come under acceptance. So increasing their tolerance means increasing their acceptance for certain side effects that you cannot problem solve. Then I already discussed this next point, discussing tools to manage side effects. If there are tools available from the psychiatrist and from the therapist, what kind of tools we can use? We will try to find these tools. Then highlighting again, I tell them also, some of my clients tell me, please don't tell this to the psychiatrist. I did not take my dose. I don't want you to inform to the psychiatrist. In the very first session only, I tell them, each session, me and your psychiatrist, we are going to discuss. We are going to have our own discussion. We will share our reports with each other. I know it is upsetting to you, but it's very important for our management and our treatment plan. So I tell them that I'm working in collaboration only with a psychiatrist. So if the psychiatrist has said this medication, this mg, that's what we are going to follow. This generally happens with substance use as comorbidity, because some of my clients tell me, I'm not taking medication because today I'm going and drinking. But please, I'm telling this to you, don't tell to the psychiatrist. I acknowledge their concern, but I tell them I will have to inform the psychiatrist. If you're going to drink and you're going to miss the medication, yes, I think I'll have to inform. Sometimes they drink and have the medication. That also you have to inform. So unfortunately, we get their concern, but substance use and psychiatric medication, very, very unhealthy combination. And it can have very negative consequences. So this is something that you should not take lightly. Okay. And the last is medication record. I also tell them to maintain a log of their medications, which medications they are on. Okay. How are they feeling about the medication on a scale of 0 to 10? And the third is what possible side effects you are seeing. And sometimes, most of the times I've seen, if they don't want to maintain this log after your session, in the session only start maintaining the log with them. I told you this is a trick. This is a very good collaborative trick. In the session only start with some assignments so that you can monitor their work and you're getting the job also done. Are we clear here? So this is one medication log, but there is also another medication log which is already there on different websites. You can even use that. As I told you, I use a simple technique. Medication, how am I feeling on a scale of 0 to 10, and side effects. But in case you would like to look at another log, I have this also. So what is the type of medication, what is the name of the medication psychiatrist has given me? What kind of dosage? I have to take it once a day. What kind of dosage is there, and what are the side effects? Then this is what here, last point is questions I might have for my doctor or mental health practitioner. So regarding the medication, if you have any questions, please put it down here. So this also helps. Are you clear? So I think for today, this is good. We are going to meet again tomorrow, 6 to 8, and we will discuss. The third column, Parvati, I mentioned was side effects. What are the side effects of the medication? Quickly recap, we started with specific features of bipolar disorder 1, disorder 2. We looked at some comorbidities. Then we also looked at contributory factors that contribute to the development of bipolar disorder. Then we also looked at, then we started with CBT model. Then we looked at Indian statistics. Then we looked at CBT model for bipolar disorder, where component 1 was understanding bipolar disorder, socializing clients. 2, what is bipolar disorder? That was the first component. Then we discussed about, what was the second one? After understanding bipolar, you remember?
The role of family.
The role of
Psychoeducating.
Psychoeducating the family members about the disorder, sometimes psychoeducating even the client about the role of family involved. That is also pretty important. Then we talked about intake interview, some questions, and then we are looking at non-adherence to medication, and we have completed that aspect also. Tomorrow we will continue from this. Reshma, if it is a quick question, yes, please ask.
Well, I have a few, but I'll just ask you one, which is how long does it take to diagnose this? Because I have a client who I suspect is dealing with this, but the psychiatrist which he went to said you have depression and anxiety. And so how long will it take, or does it take generally to diagnose, to come upon that, you know, it's all of these things and it's bipolar and it's not just depression, anxiety?
Yeah.
See, Reshma, this answer, there is no one straight answer to this, because
வேற இருக்குல்ல.
it again depends on the psychiatrist, what kind of information is available to the psychiatrist. Sometimes we look at misdiagnosis, but we don't look at this component. Parvati, can you please be on mute? I'm not able to mute you. Yeah. So sometimes what happens, clients may not give all the information also. They come alone. They may not come with caregivers. So I think all these factors together will decide whether the diagnosis is going to happen properly or not. Right, Reshma? So there is no one answer to this question.
So the psychiatrists also have very little time. That's one thing, which I think is a very crucial factor. The second thing, you keep saying, work with the psychiatrist, but they don't seem very keen to work with us.
I would say create your own community of mental health professionals who would want to work with a therapist. Problem solving, Reshma.
Yeah,
You
makes
directly
sense.
come to
Yes.
problem solving. That if you get some kind of feedback like this, that the psychiatrist is probably not working for whatever reasons, we are not going to assume anything. I have changed the strategy only now. Work with only those mental health professionals who respect psychotherapy also, and who respect the role of medication also. Okay, if you have any other questions, I'm not going to take right now, because I also have a meeting, but it's not that I won't take your questions. So you can note these questions down, share it with Rajesh sir on WhatsApp. He will send it to me tomorrow at the start of my class. I will first take these questions, and then I will come to day 2. Okay. So I really had a great time sharing little information that I have about CBT for bipolar. I hope you guys are enjoying as well. And I will see you again tomorrow for day 2. Okay. Okay, everyone. Have a nice night.
Thank you so much.
Have a nice dinner. Bye.
Thank you so much, Asira.
Welcome. Bye.
Thank you, ma'am.
Thank you, ma'am.